The nervous system may be thought of as an elaborate control system that coordinates and regulates all bodily functions. It receives and interprets information from the external environment and initiates responses to the specific information internally. The nervous system is divided into two main parts. 1. The central nervous system, CNS, made up of the brain and spinal cord, and sensory reception areas to interpret pain, touch, temperature, distances, sizes, and shapes. Temporal lobe contains the auditory center for hearing and understanding spoken language. Contains the olfactory center for smell. Occipital lobe contains the visual center for seeing and reading. Cerebrospinal fluid, CSF, is composed primarily of water, glucose, sodium chloride, and protein. It is produced in the ventricles of the brain in arachnoid granulations. CSF circulates within the subarachnoid space, the ventricles, and the central canal of the spinal cord. The fluid is reabsorbed in the arachnoid villi. CSF acts as a shock absorber for the brain and spinal cord. If excess fluid forms or if fluid is not normally reabsorbed, pressure within the ventricular system increases. Brain circulation. The brain is rich with arterial circulation to satisfy its need for oxygen. Fig 21.4 shows the major cerebral arteries. Although the brain comprises only 2% of the body's weight, it consumes 20% of the oxygen supply and cardiac circulation each minute. The two major arterial systems are, 1. The carotid, and 2. The vertebral arteries. The carotid system begins as one common artery that later divides into the external and internal carotid arteries. The external carotid arteries divide to supply blood to the face. The spinal cord extends from the border of the first cervical vertebra, C1, to the level of the second lumbar vertebra, L2. 31 pairs of spinal nerve roots exit from the spinal cord, each consisting of a posterior sensory, afferent, root and anterior motor, efferent, root. These nerve roots, along with the 12 cranial nerves, make up the peripheral nervous system. Peripheral nervous system, part of the peripheral nervous system, known as the autonomic nervous system, helps to maintain homeostasis for the body. The autonomic nervous system controls the involuntary activities of the viscera, including smooth muscles, cardiac muscle, and glands. The two major subdivisions of the autonomic nervous system are, 1. The sympathetic nervous system and, 2. The parasympathetic nervous system. Stress triggers the sympathetic nervous system to increase the secretion of epinephrine and norepinephrine. These neurotransmitters increase heart rate and constrict peripheral blood vessels, causing the blood pressure to rise. This reaction to stress is called the fight or flight response. The sympathetic nervous system is also referred to as the thoracolumbar system. Age-related changes. With normal aging, the number of nerve cells decreases. Brain weight is reduced, and the ventricles increase in size. An aging pigment called lipofuscin is deposited in nerve cells, along with amyloid, a type of protein. Increased plaques and tangled fibers are found in the cerebral nerve tissue. These changes are associated with Alzheimer's disease but are also seen in the brains of people who have no symptoms of dementia. Fortunately, many more nerve cells are present than are needed for normal function. Therefore, most older people retain normal cognition and function despite the decreasing number of nerve cells. The physical examination reveals some neurologic changes typical of aging. The pupil of the eye is often smaller and may respond to light more slowly. When asked to track, follow with the eyes, a moving object, the older person's eye movements may be jerky rather than smooth. Reflexes are usually intact except for the Achilles tendon jerk, which is often absent. Older people frequently demonstrate some changes in functional abilities as well. Reaction time increases with aging, especially for complex reactions. Tremors in the head, face, and hands are common. Some older people develop dizziness and problems with balance. These are not considered normal age-related changes but may be related to disease or drug side effects. Discuss the pathophysiology of neurologic diseases and nursing assessment of neurological function. Potential causes of neurologic disorders include developmental and genetic disorders, trauma, infection and inflammation, neoplasms, degenerative processes, vascular disorders, and metabolic and endocrine disorders. Developmental and genetic disorders. Developmental disorders include structural problems such as hydrocephalus. An example of a genetic disorder is Huntington disease. Trauma. CNS injuries resulting from trauma can be life-threatening or severely disabling. Physical trauma to the nervous system may follow accidental injury, violent crime, or chemical injury caused by drugs, alcohol, or other harmful substances. Infections and inflammation. Meningitis and encephalitis are examples of disease states that cause inflammation of meningeal tissue and brain tissue, respectively. Causative agents may be viruses or bacteria and may be transmitted by a variety of vectors and routes. Neoplasms. CNS tumors may be primary or metastatic in origin. Although considerable progress has been made in treating these tumors, definitive therapy is often difficult to achieve, depending on the cell type involved in the tumor and the degree of invasion of surrounding tissue. Degenerative processes. The primary degenerative disease of the brain is Alzheimer's disease, a progressive condition that begins with memory loss and eventually results in severe mental and physical deterioration. Other degenerative disorders are multiple sclerosis, MS, Parkinson disease, amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig's disease, and Huntington disease. Vascular disorders. Any factor that interferes with blood flow to nervous tissue can lead to cell death, with resulting loss of function. Nerve tissue is so sensitive to hypoxia that cells begin to die after being deprived of oxygen for 4 minutes. Neurologic disorders associated with impaired blood flow include cerebrovascular accident, see Chapter 28, and multi-infarct dementia. Vascular abnormalities, including aneurysms and arteriovenous malformations, can rupture or prevent the delivery of adequate oxygen to affected tissue. Metabolic and endocrine disorders. The brain depends on constant supplies of glucose and other nutrients. Disturbances in glucose metabolism and electrolyte imbalances can lead to deterioration in thought processes and level of consciousness. Neurologic dysfunction can also result from accumulation of toxins, as in poisoning, renal failure, and liver failure. Nursing assessment of neurologic function. Several diagnostic tests may be done to evaluate and diagnose neurologic problems. However, any evaluation begins with an accurate assessment, which may be initiated by the nurse. The licensed vocational nurse/licensed practical nurse, LVN/LPN, assists with the assessment by collecting relevant data. Much of the assessment requires simply observing the patient and then recording the findings. Health history. The general nursing assessment of the patient with a neurologic disorder is described here. Throughout the assessment, the patient's speech, behavior, coordination, alertness, and comprehension should be noted. Chief complaint and history of present illness. An initial portion of the neurologic assessment includes an investigation of the patient's health history, particularly as it relates to the chief complaint. Document the event that prompted the patient to seek medical attention and describe any injuries. If the patient has pain, note the onset, severity, location, and duration. Past medical history. Past neurologic disorders and pertinent signs and symptoms are vital pieces of information. Ask about a history of head injury, seizures, diabetes mellitus, hypertension, heart disease, and cancer. Record dates and types of immunizations, including influenza, and list current medications. In addition, record current drugs and highlight allergies according to agency policy. Family history. Questions about the presence of neurologic disease, fit other diseases in the immediate family may elicit valuable information about risk factors, such as those for stroke or neuromuscular diseases. Therefore, Ask whether any immediate family members have had heart disease, stroke, diabetes mellitus, cancer, seizure disorders, muscular dystrophy, or Huntington disease. Review of systems. Important signs and symptoms to be documented in reviewing the system are fatigue, weakness, headache, dizziness, vertigo, changes in vision or hearing, tinnitus, drainage from the ears or nose, dysphagia, neck pain or stiffness, vomiting, problems with bladder or bowel function, sexual dysfunction, fainting, blackouts, tremors, paralysis, incoordination, numbness or tingling, memory problems, and mood changes. Functional assessment. Document whether present symptoms interfere with the patient's usual activities and occupation. Explore sources of stress, usual coping strategies, and sources of support. Physical examination. A complete physical examination, including the neurologic examination, should be done when the patient is stable. A neurologic assessment provides baseline data to compare with ongoing assessments and serves as the basis for developing the nursing care plan. 4 major components of a routine neurologic examination that provide valuable information regarding the overall integrity of the CNS are: 1. Level of consciousness, 2. Pupillary evaluation, 3. Neuromuscular response, and 4. Vital signs. You must look at the trends in the patient's neurologic status. A single finding considered in isolation may not provide a true picture of the patient's status. For example, one elevated blood pressure reading may not be significant, but continuing increases may be associated with increased intracranial pressure, ICP. Basic neurologic examination. Level of consciousness. The most accurate and reliable indicator of neurologic status is level of consciousness. Evaluate patients for orientation to person, place, and time by asking them to state their names, where they are, and what time it is. It is important to consider the degree of stimulation required to evoke a response from the patient. If the patient responds only to vigorous physical stimulation, consciousness is more impaired than if the patient responds immediately to a verbal greeting. Consider patient behavior in response to stimulation. Does the patient respond pleasantly, or is he or she combative, agitated, or lethargic? All of these observations provide additional information regarding mental status. Pupillary evaluation. The second major component of the neurologic assessment is the pupillary evaluation. To evaluate the pupils, assess and compare their size, shape, and reactivity. Pupils are normally about 3 mm in size, round, and react briskly to light. Changes in equality or reactivity from one assessment to the next may indicate neurologic deterioration. Neuromuscular response. Assessment of neuromuscular response provides a means of evaluating cerebral and spinal cord function. All electrical impulses responsible for eliciting motor responses are initiated in the frontal lobe of the cerebral cortex. The impulses travel down the brainstem into the spinal cord. Motor spinal nerve roots then stimulate muscle movement. Vital signs. Monitoring pulse, respirations, and blood pressure provides highly reliable information regarding neurologic well-being. However, changes in vital signs are late indicators of deterioration. Elevated temperature may be associated with infection or with impaired thermoregulation. Glasgow Coma Scale is commonly used to rate the patient's eye-opening response, motor response, and verbal response. The numeric ratings are totaled for a summary score. A normal, alert person would score 15, a person in a coma would score 7 or less. Discuss diagnostic test and procedures. Discuss the cranial nerves. Cranial nerve function, sensory function, neuromuscular function, coordination, and balance, and reflexes are components that can assist the practitioner in localizing the area of injury or disease and in developing a plan of care relevant to the individual patient. Cranial nerves. The cranial nerves mediate various motor, sensory, and autonomic functions. The cranial nerves enter and exit the brain rather than the spinal cord. Their main function is to control sensory, motor, and autonomic activities of the head and neck. The vagus nerve affects autonomic cardiac, respiratory, gastric and gallbladder function. Olfactory, responsible for the sense of smell. Tested by exposing one nostril at a time to common odors. Optic, sense of vision. Tested with visual acuity, visual fields, optic disc. Oculomotor, movement of the eye, pupillary accommodation and constriction, raises upper eyelid. EOMs, doll's eyes, light examination, direct and consensual accommodation. Trochlear, movement of eye, down and in. EOMs and doll's eyes tests. Trigeminal, facial sensation to hot/cold, light touch, chewing, branches, ophthalmic, maxillary, mandibular. Respective testing of 3 divisions. Clench jaw and check masseter and temporalis muscles, jaw and corneal reflex. Abducens, movement of the eye, laterally, EOMs and doll's eyes test. Facial, facial expressions, salivation, lacrimation, taste. Tested by telling the patient to smile, frown, puff out cheeks, show teeth, taste, close eyes. Acoustic, hearing, equilibrium. Vestibular, usually not test. Glossopharyngeal, motor response limited, sensory on posterior tongue. Innervate carotid body and sinus. Swallow on command, gag reflex, and taste are assessed. Vagus, movements of the pharynx and larynx. Raises palate. Innervates organs of thorax, abdomen. Gag reflex, midline uvula elevation. Spinal accessory, movements of shoulders and neck. Shrug shoulders and turn head against resistance. Hypoglossal, movements of tongue for speech and swallowing. Protrude tongue, deviates to affected side. Coordination and balance, both the cerebellum and the cerebral cortex influence coordination and balance. Cerebellar dysfunction creates loss of steady balanced posture and gait on the ipsilateral side, same side, as the brain lesion. However, lesions of the cortex cause motor dysfunction on the contralateral side as the lesion. Observation: patient's routine activity, such as ambulation, feeding, or performing ADLS, can give valuable information about coordination and balance. In the assessment of balance, ask the patient to walk 10 to 20 feet away, turn, walk back toward you. Observe the patient's gait and arm swing, then ask the patient to walk a straight line in heel-to-toe fashion. To perform the Romberg test, have the patient stand with the feet together and arms at his or her sides. Instruct the patient to close their eyes and maintain that position. Stay close to the patient's side in case of a fall. Normally the patient will display only slight swaying. To evaluate coordination of movements, ask the patient to pat his or her knees with the palms of the hands and then with the backs of the hands in a rapid, alternating pattern. Hold up one finger and instruct the patient to touch it with his or her index finger. Ask the patient to touch his or her nose with the index finger, first with the eyes open and then with the eyes closed. Ask the patient to run the heel of one foot down the shin of the other leg and then repeat with the opposite heel. Alternate tapping the heel and then the toes of one foot and then the other foot. Normally these responses are done smoothly and normally. Neuromuscular function: evaluate individual muscle groups before assessing their size, tone, and strength. Upper arm strength is evaluated by having the patient provide resistance to a movement. For example, you can ask the patient to extend the arms and bend the elbows, while alternately trying to push the examiner away or pull the examiner forward. Strength of the intrinsic muscles of the hand is tested by having the patient spread fingers apart and then resist having them pushed together. Strength of hand grasp is tested by putting one finger on top of another so that a squeeze will not painfully press the knuckles together. You also instruct the patient to lift each hand or raise a finger on each hand. A subtle weakness in upper arm strength is assessed by having the patient extend both arms forward with the palms up. Ask the patient to close his or her eyes and maintain the position for 10 to 20 seconds. With normal strength, the arms remain steady. In the presence of slight weakness, the weak arm will rotate internally and drift slightly downward. This is referred to as ulnar or motor drift. To evaluate strength of the legs, position the patient supine and ask him or her to raise one leg at a time. The patient with normal strength can lift the leg 90 degrees. Test the strength of other muscles as indicated. Sensory function. Many tests of sensory function exist, including evaluation of the patient's perception of pain, temperature, light touch, vibration, position, and tactile discrimination. All sensory testing is done with the eyes closed. Apply various stimuli to the skin and ask the patient to identify the type of stimulus perceived. Pain can be evaluated using a wooden applicator that is broken to create a sharp point. This broken applicator is used as the sharp stimulus, whereas the cotton end is used as a dull control stimulus. Ask the patient whether the sharp or dull sensation is being felt. Recognition of the sharp point indicates the ability to perceive pain. Temperature. Temperature perception can be tested by touching test tubes containing hot or cold water to the patient's skin and asking the patient to distinguish between hot or cold. Light touch. A wisp of cotton brushed against the skin is used to assess perception of light touch. Ask the patient to state when the sensation is felt. Vibration. To test vibration, strike a tuning fork and touch the base to a joint in the great toe or a finger. Ask the patient to report when the vibration is felt and when it stops. The examiner actually stops the tuning fork from vibrating. If the sensation not perceived, repeat the test on a more proximal joint until the patient perceives it. Position. To test direction, lightly hold on the patient's great toe or a finger on the sides and move it up and down. Then ask the patient to identify the direction of the movement. Tactile discrimination. Tests for tactile discrimination include stereognosis, graphesthesia, and point localization. To test stereognosis, place familiar object in the patient's hand and request identification using only one hand. Graphesthesia tests the patient's ability to recognize a number or letter written on the palm with a dull object. To test point localization, briefly touch the skin and ask the patient to touch the place where the sensation was felt. Reflexes. A reflex is unconscious, involuntary response that is entirely mediated at the level of the spinal cord, without the input from higher brain centers. The knee jerk represents a simple reflex. When a stimulus is applied to the patella, the sensory root of the spinal nerve transmits the impulse to the spinal cord. At the cord, the impulse is relayed to the motor nerve root, which elicits the knee jerk. Other common reflex tests. Biceps, flexion of forearm. Triceps, extension of forearm. Brachioradialis, flexion and supination of the forearm. Quadriceps, extension of the lower leg. Achilles, plantar flexion of foot. Clonus, repetitive movement after brisk dorsiflexion of the foot. Although these reflexes are normal, others only appear in pathologic states. Babinski reflex accompanies abnormalities in the motor pathways originating in the cerebral cortex. Assess for it by stroking the lateral side of the bottom of the foot and across the ball of the foot with a blunt object and observing the resulting movement of the toes. Normally the toes curl downward. However, in the presence of cortical dysfunction, the big toe bends upward and the other toes fan out. Lumbar puncture. A lumbar puncture is an invasive procedure that is used most often to detect infections and other disorders of the CNS, tumors, and hydrocephalus. A local anesthetic is used to anesthetize the puncture site. Then a cannula is inserted into the subarachnoid space at the level of the fourth and fifth lumbar vertebra. Entering here allows the physician to avoid trauma of the spinal cord, which ends at the level of the second lumbar vertebra. Once the needle is in place, a sample of CSF is collected for laboratory analysis. CSF specimens are placed in test tubes and labeled, with the first specimen usually being discarded because it may contain blood from the puncture. Normal CSF has the following characteristics: pressure 50 to 175 mm H2, pH 7.3 to 7.4, clear and colorless, fasting glucose 40-80 mg/dl, white blood cells 0 to 5 small lymphocytes/mm3. Injuries from the lumbar puncture are rare, but some patients may have a headache resulting from CSF leak. Leaks are sometimes treated with a blood patch, which is created by injecting a small amount of the patient's blood into the lumbar puncture site. The blood clots and seals the site. Electroencephalography. The EEG is a graphic representation of electrical activity in brain cells. Small electrodes are placed at various positions on the head to detect electrical signals generated from neurons located near the surface of the cerebral cortex. It is an excellent tool in the diagnosis of seizure activity. Some people have misconceptions about EEG. Assured the patient that no electrical shock will be experienced, the examiner is not able to read the patient's mind, and that the test is not done to detect mental illness. Fatigue stresses the brain and may evoke abnormal activity not usually seen on the EEG. Therefore, patients may be evaluated with a sleep-deprived EEG, in which they are awakened after short sleep in an effort to elicit such activity during the test. Electromyography. EMG studies the response of peripheral motor and sensory nerves to electrical stimuli. Needle electrodes are placed on several points over a nerve and over the muscle supplied by the nerve. Stimuli are administered and the effects are recorded on an oscilloscope. Radiologic studies. Brain scan. The brain scan shows the pattern of distribution of radioactive isotope injected intravenously. It is useful in detecting brain abscesses, tumors, conclusions, vascular occlusion, or hemorrhage, and hematomas. The patient is given potassium chloride 2 hours before the isotope is injected to prevent excessive isotope uptake. The isotope is given immediately before the scan is done. While the patient lies still on the stretcher, the scanner, which is somewhat like a radiograph machine, moves back and forth over the head. No sensation is associated with the scanning process. The scan is repeated an hour later. Cerebral angiography and digital subtraction angiography. Cerebral angiography provides images of cerebral, carotid, and vertebral blood vessels. A catheter is inserted into an artery and advanced into the carotid or vertebral arteries. A contrast dye is injected in a series of radiographs are taken. Angiography is the most definitive diagnostic test in the diagnosis of cerebral aneurysm or congenital vascular disorders, such as arteriovenous malformation. Risk includes severe allergy to contrast media, embolus, hematoma, hemorrhage, renal toxicity, transient ischemic attack, infection, and loss of consciousness. Digital subtraction angiography is a complementary, computer-assisted radiographic procedure for visualization of cerebral vessels. Compute tomography. The evolution of computed tomography represents one of the most significant developments in neurologic diagnostic procedures. CT is an excellent tool in the evaluation of trauma, tumors, and hemorrhage. Enhancement of an area may be achieved by injecting contrast medium, therefore, an allergy to such medium must be reported to the radiologist in advance. The entire scanning procedure lasts 15 to 20 minutes and generally requires no advanced preparation or post-procedure care. Magnetic resonance imaging. One of the latest tools in neuroradiology is magnetic resonance imaging. Unlike CT, MRI does not expose the patient to radiation. It is a non-invasive examination that involves placing the patient in a strong magnetic field and then applying burst of radio frequency waves. Sophisticated technology converts information about the movement of molecules in the tissue to precise clear images. Magnetic resonance angiography is a special technique that allows the measurement of flow through blood vessels. Depending on the type of equipment available, metal prosthesis, pacemakers, and Darius implants may contraindicate MRI. This non-invasive procedure is painless, has no known risk and requires no preparation. Show video of cranial nerves assessment. Discuss drug therapy, preoperative and postoperative nursing care. Cranial nerve examination nursing cranial nerve assessment I-12, 1 to 12. Drug therapy. Antimicrobials, analgesics, anti-inflammatory agents, corticosteroids, anticonvulsants, diuretics, chemotherapeutic agents, and dopaminergic, anticholinergic, cholinergic, and antihistamine medications. Surgery. A craniotomy, surgical opening of the skull, may be done to treat tumors, correct defects, evacuate hematomas, and relieve pressure associated with trauma. A craniectomy is the excision of a segment of the skull. A cranioplasty is any procedure done to repair a skull defect. Preoperative nursing care. Document the patient's neurologic status to provide a baseline for evaluating postoperative progress. Encourage the patient to ask questions and to express fears. If the patient has cerebral edema, parenteral corticosteroids may be ordered to help reduce cerebral swelling. Hair on part of the scalp is usually clipped. Because shaving the head can be very stressful for patients, they should be assured that the hair grows back. Sometimes clipping is done after the patient is anesthetized to reduce the trauma. Advise the patient's family that a craniotomy can take as long as 12 hours and that they will get progress reports during the procedure. Postoperative nursing care. Postoperative craniotomy care includes monitoring level of consciousness, vital signs, movement and strength, pupil size and response to light, and speech. Signs and symptoms that may be related to complications are headache, visual disturbances, vomiting, seizures, and respiratory depression. Vital signs are recorded, and neurologic checks are done hourly until the patient is stable. Maintain intake and output records and inspect any dressings for evidence of bleeding or CSF drainage. Note drainage from the ears or nose. If this occurs, a dressing may be placed loosely to absorb the drainage. Replace the dressing if it becomes wet because the moisture can harbor bacteria. On dressings, CSF appears as a pink stain surrounded by a lighter ring described as a halo. However, other fluids may produce halos as well. It is no longer recommended to check CSF with a dipstick for glucose because dipsticks are calibrated only for the specific fluids they were designed to test. Report any signs of deteriorating neurologic status to the physician immediately. The physician prescribes the patient's position and usually specifies that the head of the bed be elevated about 30 degrees. If the patient has an external ventricular drainage system, use strict aseptic technique when changing the insertion site dressing and the drainage bag. Keep the zero reference point of the drip chamber of the drainage bag at the level of the external auditory canal, or at the level the physician prescribes, to prevent drainage of excessive CSF. When the patient is being repositioned, clamp and then restore the drainage tube to the correct level and unclamp it. In addition to the usual surgical complications, the patient having a craniotomy is at risk for increased ICP, CSF leak, meningitis, and seizures. Other complications depend on the area of the brain affected and could include paralysis, memory loss, confusion, and impaired speech, vision, or hearing. 5. Discuss intercranial pressure, types of intercranial herniation and medical treatment. Increased intracranial pressure. Increased ICP poses an extremely serious threat to the neurologic patient. Understanding the physiology as well as the signs and symptoms will enable you to recognize the problem and respond appropriately to prevent life-threatening consequences. Pathophysiology. Anatomically, the skull is a cavity with rigid sides and an opening at the bottom. This cavity contains the brain, blood, and CSF, which are the components that exert pressure in the cranium. This pressure, or ICP, is normally 0 to 15 mm Hg. In the course of a day, ICP fluctuates minimally because alterations are usually corrected rapidly. The Monro-Kelly hypothesis describes the adaptations that must occur in the three components, brain, blood, and CSF, for ICP to remain normal. If the volume of one component increases, ICP will rise unless a subsequent decrease occurs in the other two components. For example, if a brain tumor increases the volume of brain tissue, ICP will rise unless the volume of both blood and CSF decreases. As ICP increases, the perfusion, delivery of blood and oxygen, to brain tissue decreases. This can be measured by calculating cerebral perfusion pressure, CPP, which is obtained by subtracting the ICP from the mean arterial pressure, MAP. CCP equals MAP ICP. A minimum perfusion pressure of 70 mm Hg is necessary to ensure adequate cerebral functioning. If perfusion pressure falls to 40 mm Hg, ischemia occurs. A perfusion pressure of 30 mm Hg or less is incompatible with life. To increase perfusion pressure, ICP must be decreased. Signs and symptoms. To detect increases in ICP and assess the adequacy of perfusion, observe for specific signs and symptoms. Assess the patient's level of consciousness, pupillary characteristics, motor function, sensory function, and vital signs to detect signs of increasing ICP and initiate prompt treatment, if necessary. Level of consciousness is the most reliable indicator of mental status because of its extreme sensitivity to oxygen levels in the cerebral blood. As ICP increases and perfusion is reduced, oxygen delivery to cerebral tissue is also reduced. Changes in level of consciousness are the earliest changes seen in ICP. These changes may be very subtle, with minimal agitation or drowsiness, or quite extreme, with profound unresponsiveness. Patients who are restless and agitated or suddenly quiet must be closely monitored, and significant changes must be reported. Classic pupillary changes are seen with increasing ICP. As pressure rises, the pupil progresses from its normal size to a dilated state described as a blown pupil. The pupil becomes dilated and fixed and no longer reacts to light. These changes occur because of pressure on the oculomotor nerve, third cranial nerve. This is a late sign of increased ICP. Another major indicator of increased ICP is altered motor function. As the motor areas of the frontal lobe are compressed by rising pressure, deficits develop on the side opposite the expanding mass. When deficits are on the opposite side from brain injury, they are said to be contralateral to the injury. For example, if a tumor exists in the right side of the brain, motor deficits will appear in the left side of the body. The deficits may involve a single extremity or an entire side. Hemiparesis, weakness on one side, or hemiplegia, paralysis on one side, may be seen. The earliest sign of a change in motor function is a motor drift. As increased pressure becomes more extensive, abnormal posturing may be evident. As increasing pressure is exerted on the cerebral tissue above the midbrain, a pattern known as abnormal flexion, decorticate, posturing can be observed. The patient exhibits abnormal flexion in the upper extremities, with extension of the lower extremities. Increasing pressure affecting the midbrain or upper pons causes extension, decerebrate, posturing. The lower extremities remain extended and the upper extremities are abnormally extended as well. Hypothalamic impairment results in the loss of temperature control. As ICP compresses the tissue around the hypothalamus, it becomes ischemic and unable to regulate body temperature. ICP elevations evoke an increase in systolic blood pressure with little or no associated increase in diastolic blood pressure. This results in a widening pulse pressure, defined as an increasing difference between systolic and diastolic blood pressure values. Initially, the heart rate may be slightly accelerated. However, as ICP compresses the center for cardiac control in the brainstem, the heart rate becomes slow and irregular. Alterations in respiratory pattern are directly related to the extent of tissue compression. Although it is extremely important to monitor vital signs in the neurologic patient, remember that changes in pulse, respiratory pattern, and blood pressure are late signs of increasing ICP. The combination of hypertension, bradycardia, and a widening pulse pressure is known as Cushing's triad. Cushing's triad is generally associated with increased ICP, but it is unreliable in determining the severity of neurologic compromise. Medical treatment. Prompt treatment of increased ICP is vital for survival. Measures to lower ICP include positioning, hyperventilation, fluid management, mechanical drainage, and drug therapy. The jugular vein is the primary route for venous outflow from the brain. It has long been thought that raising the head of the bed 30 to 45 degrees improves the flow of venous blood from the brain, thereby decreasing cerebral blood volume and ICP. However, recent research indicates that perfusion pressure may be better preserved if the head of the bed is elevated no more than 30 degrees. Further investigations may lead to some changes in current practice. As oxygen delivery to cerebral tissue becomes more impaired, the level of carbon dioxide in the tissue increases. Increased carbon dioxide leads to dilation of cerebral blood vessels, thereby increasing the cerebral blood volume and ICP. With controlled hyperventilation, the excess carbon dioxide is eliminated, causing blood vessels to constrict and ICP to fall. Controlled hyperventilation is best achieved by mechanical ventilation. It decreases ICP within 1 to 2 minutes, but its effectiveness is diminished after 36 to 48 hours. Hyperventilation does have risks. Excessive vasoconstriction reduces cerebral oxygenation and worsens ischemia. Hyperventilation may be reserved for situations in which other treatments fail to reduce ICP. The goal is to achieve normocania. The patient must have adequate fluids to maintain cerebral perfusion pressure, CPP. Fluid volumes are often increased to boost perfusion. Patients with questionable cardiac function must be monitored closely for fluid volume excess. A specialized catheter, called a ventriculostomy catheter, can be placed in the brain to drain excess CSF. After placement, the catheter is connected to tubing and a collection bag for gravity drainage. Drainage of CSF lowers ICP. Maintaining absolute sterility when managing this system is important to prevent contamination through the tubing to the brain. Intravenous mannitol administration is one of the mainstays in the treatment of increased ICP. Mannitol is a hyperosmolar diuretic that draws edema fluid from the tissue spaces into the bloodstream. The mannitol and excess fluid are then eliminated through the kidneys. A rebound phenomenon may occur after administration. During administration, some of the medication crosses the blood-brain barrier. As mannitol is eliminated from the bloodstream, fluid is pulled into the brain. Other diuretics, such as furosemide, may also be used to reduce edema. Corticosteroids, although controversial, may be used to help decrease cerebral edema and ICP. They decrease the edema, thereby lowering the elevated ICP associated with CNS tumors. Dexamethasone, Decadron, is a major agent used for patients with neurologic disorders. 6. Discuss the various types of headache and seizure disorder, nursing care, and patient teaching. Sarah. Headache, most common type of pain. It's a symptom, rather than a disease, that has many causes. 4 common types of headaches are, 1. Migraine headache, 2. Cluster headache, 3. Tension headache, and 4. Headache related to disorders of the eyes, teeth, or sinuses. For headaches associated with these and other conditions, treatment depends on the underlying cause. Migraine headache results from intracranial vasoconstriction followed by vasodilation. Although no single cause is known, it may be triggered by menstruation, ovulation, alcohol, some foods, and stress. Patients may experience depression, irritability, vision disturbances, nausea, and paresthesia before the onset of pain. The pain is usually unilateral, often begins in the temple or eye area, and is often very intense. Tearing and nausea and vomiting may occur. The patient is hypersensitive to light and sound and prefers a dark, quiet environment. Mild migraines may be treated with acetaminophen or aspirin, but more severe ones may be treated with ergotamine, Cafergot, or sumatriptan, Imitrex, administered as a tablet or by auto-injector for self-injection. However, prevention should be emphasized. Medications such as beta blockers or calcium channel blockers may help to control the vascular influences. Identification and avoidance of triggering agents, such as particular foods, example chocolate, yogurt, aged meats, cheeses, beverages, example alcohol, red wine, or emotional stress, may also prove helpful. To treat chronic migraines in adults, onabatulinumtoxin A, Botox, is used for those individuals with migraine headaches greater than 14 days of the month that last more than 4 hours a day. Injections are given every 12 weeks to prevent migraine headaches before they start. Cluster headache occur in a series of episodes followed by a long period with no symptoms. They are intensely painful and seem to be related to stress or anxiety. Unlike migraines, cluster headaches usually have no warning symptoms. They are also shorter in duration than migraines. Treatment may include cold application, indomethacin, indocin, and tricyclic antidepressants. Tension headache result from a prolonged muscle contraction associated with anxiety, stress, or stimuli from other sources such as a brain or an abscessed tooth. The location of the pain may vary, and the patient may have nausea and vomiting, dizziness, tinnitus, or tearing. Tension headaches may persist for days or even years. Treatment measures include correction of known causes, psychotherapy, massage, heat application, and relaxation techniques. Analgesics, usually non-opioid drugs, may be prescribed along with other medications to reduce anxiety. Complementary and alternative therapies. Complementary and alternative therapies are excellent adjuncts in the management of headache. Progressive muscle relaxation techniques, imagery, acupuncture, and electromyography biofeedback may reduce the frequency and intensity of headaches. Seizure disorder. The electrical impulses generated in the brain normally spread in a very organized fashion. However, in the patient with a seizure disorder, electrical impulses are conducted in a highly chaotic pattern that yields abnormal activity and behavior. Seizure activity involves many hyperactive neurons that use excessive oxygen and glucose. Therefore, oxygen and glucose stores may be depleted, leading to permanent neurologic damage. Seizure activity may be related to trauma, reduced cerebral perfusion, infection, electrolyte disturbances, poisoning, or tumors. A genetic tendency for such activity may also exist. Medical diagnosis. Diagnostic testing for seizure activity is often directed toward ruling out specific problems. An accurate history of the seizure disorder can provide clues to the type of seizure disorder, possible triggering events, and the origin of activity. Unexpected seizure activity is often very frightening to the family, the nurse, or other healthcare provider who may be the first reliable eyewitnesses. If you observe a seizure, note the patient's behavior before, during, and after the seizure, as well as the duration of the seizure. The patient's electroencephalography, EEG, tracing, which records the electrical activity of the brain, is used to detect abnormal brain activity. Seizure classification. Two broad classifications of seizures, based on the patterns of activity, are 1. Partial seizures and 2. Generalized seizures. Abnormal electrical activity may be generated in a specific area of the brain, remain localized and stop, or the activity may spread to adjacent neurons, but remain fairly localized. These patterns of activity are termed partial, or focal, seizures because they involve only a part of the brain. The observed activity corresponds to the area of the brain affected. In addition, partial seizures may recruit a sufficient number of adjacent cells and the activity can spread throughout the cerebral hemispheres. This is known as a partial seizure with secondary generalization. Generalized seizures involve the entire brain from the onset and are associated with loss of consciousness. Some sources use the term unclassified seizures for those that are not readily classified as partial or generalized. Partial seizures, simple or complex. Simple seizures affect part of one cerebral hemisphere and consciousness is not impaired. A simple partial seizure may include motor, somatosensory, autonomic, or psychic symptoms. Focal motor seizures are a subtype of simple seizures in which the abnormal brain activity remains localized to a specific motor area. This may occur with or without Jacksonian march, the term used when the abnormal activity begins in one area and then marches, spreads, to adjacent motor areas. For example, the simple focal motor seizure may begin with the eyelid, then spread to the same side of the face, and progress to involve the arm and leg on that side. In a complex partial seizure, previously called a psychomotor or temporal lobe seizure, the patient's consciousness is impaired, and the patient may exhibit bizarre, repetitive behavior. Simple partial and complex partial seizures can progress to involve the entire brain. These are referred to as partial seizures with secondary generalization. Generalized seizures involve the entire brain from the onset. Consciousness is lost during the ictal seizure period. One type of generalized seizure is the tonic-clonic seizure, previously referred to as a grand mal seizure. The tonic phase of the seizure is characterized by stiffening of the muscles or extremities with loss of consciousness. After the tonic phase, a rhythmic movement of the extremities occurs, called the clonic phase of the seizure. When seizure activity ceases, the postictal phase, the patient is sleepy and has no memory of the seizure. The patient may be incontinent of urine during a generalized seizure. Other types of generalized seizures are absence, myoclonic, and atonic seizures. Absence seizures, previously called petit mal, are brief periods of loss of consciousness in which the person may appear to be daydreaming. Absence seizures may be associated with automatism such as eye blinking and lip smacking. These seizures are generally identified during childhood. During a myoclonic seizure, the person has only brief jerking or stiffening of the extremities. Atonic seizures were formerly called drop attacks because a sudden loss of muscle tone causes the patient to collapse. Status epilepticus, medical emergency in which the patient has continuous seizures or repeated seizures in rapid succession for 30 minutes or more. The prolonged seizure activity depletes the brain of oxygen and glucose, which can lead to permanent brain damage. Aura, some people experience an aura preceding a seizure. An aura is a sensation such as dizziness, numbness, visual or hearing disturbance, perception of an offensive odor, or pain. It occurs before loss of consciousness. The individual retains the memory of the aura and is able to recognize the oncoming seizure. Medical treatment. Most desirable treatment of a seizure disorder is the resolution of the underlying condition. For example, if a tumor causes seizure activity, surgical excision of the tumor would be the most desirable therapy. However, if a cause is not readily identifiable or correctable, medical management is implemented. Anticonvulsant drug therapy provides satisfactory chemical control of seizure activity in about 75% of patients. A variety of drugs are available, some being more effective in certain seizure disorders than others. The selected drug is introduced, and the dose is gradually increased until a therapeutic level is achieved. If good seizure control is not accomplished with one drug, combinations of drugs may be prescribed. Status epilepticus is treated with intravenous anticonvulsant drugs. If the patient does not respond to anticonvulsants, general anesthetics and neuromuscular blockers may be used. Surgical treatment. Patients whose seizures are poorly controlled with medication may be candidates for surgical procedures to decrease or control seizures. Procedures include removal of seizure foci in the temporal lobe and pallidotomy or implantation of a vagal nerve stimulator. Nursing care. With a seizure disorder, it is especially important to describe the seizure episode, including the postictal period, and to document drug therapy. Interventions. Risk for injury. You must protect the patient from injury during and after a seizure. Most agencies require that the side rails of the bed be up and padded, a suction machine be readily available, and the bed be maintained in the low position. Some experts believe that padding the side rails is unnecessary, is cumbersome, and may have a negative emotional effect on the patient and visitors. However, it is a common practice used to protect the patient in case he or she strikes the rails during a seizure and is referred to as seizure precautions. If the patient has a seizure, quickly move objects away from the patient. If the patient falls to the floor, the head may be cradled in your lap to prevent injury. Do not attempt to restrain the patient. In the past, it was common practice to attempt to insert a tongue blade or oral airway between the teeth to prevent biting of the tongue. However, this is no longer recommended. Attempts to force an object between clenched teeth may result in injury to the mouth and do not help if the tongue has already been bitten. The patient will not swallow the tongue, but it may fall back and occlude the airway. Turning the patient to one side can help to maintain a patent airway. When seizure activity ceases, the patient is typically drowsy and needs to rest. During this postictal period, the nurse should provide for quiet and privacy. Afterward, he or she should document the conditions and any unusual behaviors that preceded the seizure, the length of the seizure, associated patient activity, deviation of the eyes, and any incontinence. In addition, document any lingering effects and the time before recovery. Ineffective coping can be related to lack of information or misconceptions and may be reflected in non-compliance with prescribed therapy, anxiety, or social isolation. Important aspects of nursing management include not only the care of the patient during hospitalization, but also teaching the family and patient about the seizure disorder and the therapy. Deficient knowledge, because a seizure disorder is often a lifelong problem, patient teaching must be directed toward helping the patient and family adjust to a chronic condition. Patients must adjust physically, psychologically, and vocationally to the changes brought on by the disorder itself, as well as to the side effects of the medications. The nurse should encourage the patient to ask questions and to express concerns. Pharm capsule, sudden discontinuance of anticonvulsant drugs can trigger seizure activity. Patient teaching. Factors that may trigger a seizure are fatigue, stress, fever, visual disturbances, alcohol, failure to take medication, and large caffeine intake. When an impending seizure is perceived, immediately seek a safe place. Know your prescribed drug names, dosages, schedules, and side effects to be reported to the physician. Consult your physician regarding the use of generic substitutions for your drugs. Never stop taking your seizure medication without direction from your physician. Psychologic counseling may help you to deal with stress associated with this disorder. Always wear a medical alert tag, which states that you have a seizure disorder, and carry a card that specifies drug therapy, physician, and individuals to be contacted in an emergency. The local chapter of the Epilepsy Foundation is an excellent resource. 1-800-332-1000, www.efa.org. A sensation that warns of an impending seizure is called an aura. Common sensations include dizziness, numbness, visual or hearing disturbance, pain, and perception of an offensive odor. Management of seizures. Dose. Do remove any objects that could cause harm. Do turn the person to one side if possible. Do note the time the seizure began and how it progressed. Do assess and document postictal, post-seizure, status. Do allow the person to rest quietly. Do call a medical emergency if a generalized tonic-clonic seizure lasts more than 4 minutes or if seizures occur in rapid succession. Do nots. Do not restrain the person unless he or she is in grave danger of severe injury. Do not attempt to force anything between the person's teeth. Health promotion. Patients with seizure disorders should receive the following interventions as necessary. Prevention of seizure disorder. Promote general safety behaviors such as use of helmets and seat belts. Obtain perinatal care, for pregnant women and those planning to become pregnant. Patients with seizure disorder should avoid alcohol use. Get adequate rest. Engage in stress-reducing activities such as meditation and visualization. Maintain general health through proper diet and exercise. 7. Discuss head injury, nursing care, and preventing head injury. Aerial. Head injuries. Traumatic brain injury is a leading cause of death caused by trauma in the United States. The most common causes of hand injuries are motor vehicle accidents, assaults, and falls, with drugs and alcohol abuse being major contributing factors. Several different types of injuries can be identified. Scalp injuries include lacerations, contentions, abrasions, and hematomas. They may bleed profusely and may or may not be associated with skull or brain injuries. Concussion. I think ocean is a head trauma in which no visible injury exists to the skull or brain. The patient has a massive consciousness lasting less than 5 minutes and may have a headache, amnesia brought the event, and vomiting. Hematomas. A hematoma is a collection of blood, usually clotted, that may be classified as subdural or epidural. Nursing care. Risk for ineffective cerebral tissue perfusion related to increased intracranial pressure, adequate cerebral tissue perfusion, patient alert and oriented. Ineffective breathing pattern related to increased ICP, normal oxygenation, respiratory rate of 12 to 20 breaths per minute with normal arterial blood gas values. Risk for injury related to seizures, decreased level of consciousness, disorientation, vision disturbances, absence of injury, no abrasions, fractures, or severe bruising incurred during seizures or falls. Risk for infection related to traumatic wounds or invasive procedures, absence of infection, normal body temperature without signs of wound infection, redness, edema, prudent drainage, urinary infection, or phlebitis. Impaired physical mobility, related to neuromuscular impairment, decreased mental alertness, absence of complications of immobility, intact skin, mobile joints, regular bowel